Hello, my name is Kayla Freeman, and I'm a nurse practitioner at Emory Winship Cancer Institute in Atlanta, Georgia. I'm joined today by Dr. Diarez, a medical oncologist at the Center Eugene Marquis in Rennes, France. In this section, we will be discussing the safety profiles of current and emerging ADCs used in the treatment of patients with metastatic breast cancer. So, Dr. Diarez, can you briefly discuss the basic composition of antibody drug conjugates and what are the potential reasons for toxicity?
Yes, thank you. And in fact, ADC were developed to perhaps minimize the side effect of chemotherapy, what we call the magic bullet a few years ago. And in fact, the component had, of course, a monoclonal antibody targeting a protein on the cell surface of tumoral cells, a cytotoxic payload link to the monoclonal antibody with what we call the linker. And in fact, the first generation has a no cleavable linker like TDM1, and the second one have cleavable linker. So we may have some release of the cytotoxic compound before and after the binding of the monoclonal antibody. And this may explain the fact that we have in the last generation of ADC more, I would say, chemotherapy like toxicity. And in fact, we know these three components are very important. On every modification of each component may explain differences in efficacy and/or toxicity. So that's why sometimes we will see a different toxicity, even if the payload is almost the same.
Very nicely said, Dr. Diarez. Currently, we have the approval of trastuzumab deruxtecan, trastuzumab entamzine, and sacituzumab govitecan. Also coming down the pipeline is datopotamab deruxtecan, which is currently approved in Japan, in the USA, but pending in Europe. Dr. Diarez, what are the safety profiles of the approved or established ADCs for patients with metastatic breast cancer? Across the board, we know that they do have that commonality of GI side effects as well as those hematologic side effects that can occur with these drugs.
Yes, of course. So I will begin by the first one developed trastuzumab emtansine, TDM1. And in fact, as I say, the cytotoxic payload is a microtubule inhibitor, which was very toxic as cytotoxic in the development before. But with the ADC, much less toxic. And what we did observe with TDM1 is mainly, I would say, biologic toxicity, so thrombocytopenia and increase of liver test. And this not impair the, I would say, the quality of life. We of course, we have to see that. Whereas the last generation, trastuzumab deruxtecan and sacituzumab govitecan, in fact, the payload for both is a topoisomerase 1 inhibitor, and we know from the cytotoxic chemotherapy, topoisomerase 1 inhibitors are associated with high grade of GI toxicity, nausea, vomiting, and diarrhea, and also neutropenia. So this will be the common adverse event with trastuzumab deruxtecan and sacituzumab govitecan. But perhaps I may add that important point during the development of trastuzumab deruxtecan is a toxicity we knew by the past, but a very, very low incidence, for instance, with TDM1 or even trastuzumab was ILD, interstitial lung disease, but with trastuzumab deruxtecan, it was observed in early clinical trials and even in the pivotal trials between 10 or 15% of this toxicity. And we have grade 5 toxicity, lethal toxicity. So now we have strong guidelines in order to monitor this important toxicity.
Very nice. And so next we'll kind of move along and talk a little bit of about some of the special warnings and precautions for these drugs. I know you touched on the ILD associated with trastuzumab deruxtecan. Extremely important, right? When these patients are getting these therapies. Can you touch a little bit more on some of the other precautions for trastuzumab deruxtecan, as well as trastuzumab and Tanzine, and sacituzumab govitecan?
I will say for trastuzumab deruxtecan and trastuzumab emtansine, we have to check the cardiac function because it's a trastuzumab monoclonal antibody. So we know by the past that we may observe some dysfunction, but it was not so obvious with the ADC. Important, trastuzumab emtansine, I just said that we have to check for the blood counts before the infusion, but for trastuzumab deruxtecan, important to give premedication for nausea, vomiting, and to be aware of the rate of neutropenia. And the neutropenia may be postponed not only day 8, usually with chemotherapy, but up to day 15. So again, and we will see we may have some measures, some GCSF for patients at risk of febrile neutropenia in order to deal with this toxicity. With sacituzumab govitecan, I will say the main adverse event are GI toxicity, again, nausea, vomiting, but also a very important diarrhea. And again, the diarrhea may be observed just after the infusion or after the day 15. And it's very important because it's a time where we observe neutropenia. And febrile neutropenia plus diarrhea may be very important and serious side effects. So we need to educate the patient to avoid some this grade 4 complication.
And so, Dr. Diarez, you've talked a lot about what we've seen in our clinical trials. What are some of the side effects that you're actually seeing in your clinical practice?
So the side effect in my clinical practice, again, what I say about GI toxicity, hematologic toxicity, mainly neutropenia, and ILD for trastuzumab deruxtecan, we should be aware that there is other toxicities that may be observed. For instance, a lot of chronic and low-grade toxicity, but this toxicity may impair the quality of life, like asthenia. And this ADC, I would say trastuzumab deruxtecan is a very active treatment for HER2-positive metastatic breast cancer, and patients may receive this treatment for more than 1, even 2 years. And after a very long period, we have to deal with this long-term toxicity, grade 2, but grade 2 fatigue for a patient is a very important issue too.
Yeah, and I kind of wanted to circle back just to talk again on the ILD because I know it's extremely important. With trastuzumab deruxtecan, are you seeing that often in your clinical practice, and how are you managing that?
Yes. We should not see up to this 10-15%. So there are guidelines today in order to monitor. So we have to check CT scan every 2 cycles for TDXD. Because in fact, in order to detect a grade 1 ILD, and if so, we may stop the ADC and have a survey 3 weeks after. Because if the patient is symptomatic with cause dyspnea, it's a more grade 2, and this means that we have to stop definitively the ADC. So that's why it's very important to check CT scan every 2 cycles in order to detect a grade 1 toxicity. But we will discuss, of course, patients should, of course, call if they have some dyspnea or cause in order to quickly detect this kind of toxicity. Because there is a management, and again, if we detect grade 1 or grade 2, this may be, I would say, reversible, whereas if it's grade 3, 4, sometimes patient may have a very serious CKD and even a life-threatening toxicity.
Absolutely, absolutely. So what do you think when it comes to our ADCs that are kind of coming down the pipeline, um, are we seeing any new or different adverse events that are associated with these therapies?
Yes, clearly. And in fact, for instance, if I'm speaking of datopotamab deruxtecan, is targeting TROP2 like sacituzumab govitecan and exactly have the same payload of trastuzumab deruxtecan, so the deruxtecan. And in fact, we didn't observe, like with sacituzumab govitecan, a high grade of neutropenia, but we on diarrhea, but we observed mainly stomatitis and ocular toxicity. And this was very surprising because the payload is almost the same. So there may be, in fact, as I say, as introduction, the fact that the antibody may be the difference compared to TDXD, same payload, but the antibody is different. And this may explain the difference in the toxicity. But we need to be aware because stomatitis we may prevent and give some education from the patient, as well for ocular toxicity to detect very early this kind of toxicity. Hello, my name is Véronique Diras, and I am a medical oncologist at the Centre Jeanne Marquis in Rennes, France. And today I am joined by Kayla Freeman, a nurse practitioner at Emory Winship Cancer Institute in Atlanta, Georgia, US, and Mrs Lesley Turner, a patient advocate from the UK and member of the patient advocate group Independent Cancer Patients Voice, who was diagnosed with invasive breast cancer in 2005. In this section, we will be discussing communicating ADC treatment toxicity to patients. So, in fact, we see that ADC are now a major component of treatment in metastatic breast cancer, but we are need to educate the patient about the potential toxicity and encourage shared decision making when managing patients with metastatic breast cancer. So, for your point of view, what's the rationale for patient education and shared decision making in breast cancer care? Lesley, we will begin with you as a patient.
Yes, thank you very much. I think the first thing to say is that that relationship between healthcare professionals and patients needs to be really viewed as a partnership rather than a one-way channel. And, shared decision making really does help us as patients make choices on our treatment and the care that is good and works for us. And it's very much a collaborative process and of course vital from the point of view of informed consent and all the legal ramifications that come with that. And there's quite a lot of evidence out there that shared decision making can really improve quality of life for cancer patients. So I suppose what I'm really saying is, treat everyone as an individual, because not everyone can grasp those complex medical decisions straight away. So I think that's really the point to make on this.
Yeah, so very good. I would say personalized communication.
Absolutely.
And Dr. Freeman, what is your opinion about that when you see the patient, for instance, after the oncologist?
Yeah, and for sure, I agree with everything that Leslie mentioned. I think it's extremely important to look at the patient as a whole and consider, those preferences and values that are important to your patient. I think this also helps with, treatment adherence. Picking a treatment and making them aware of the side effects so that they can have a good quality of life, but also, be on treatment for the long term.
Yeah, I agree with that. We should be partners, team of the patient, and determine what are the goals of the treatment with the patient for their goals. So, in your perspective, as a patient with breast cancer, Lesley, on what you have found to be effective and appropriate for the side effect education?
Yeah, so first of all, you want the information from a trusted source. So that's not necessarily your treating clinician. It could be your healthcare nurse or your clinical nurse specialist. So that's the first thing. And I think for us as patients, it's really important for us to understand a little bit of how the treatment works. So before you get on to side effects, just give us a little bit of an idea of how it works. We don't want, a whole PhD on it. We just want to know a little bit of the background of it. And then break the information down into small sections. And, when you're having the discussions with your healthcare team, people need to be encouraged to ask for clarification if they don't really understand it before you move on to the next section. And I think for a lot of us, we've always found it really helpful to take somebody along with us to take notes, because it's quite difficult to take everything in on the one consultation. And one of my friends actually likes to record consultations, which is possibly going a little bit too far, but it's a strategy that works for her. And others like to just take their own notes. So the information on side effects need to be given very early, but most people don't understand risk. Risk is quite a difficult concept. So it's probably more important to point out those serious, the red flag side effects and what the patient needs to look out for. So, for example, a friend of mine who's a very experienced metastatic breast cancer patient has had to come off her ADC because she got stage 3 lung disease. And she didn't realize that, the breathlessness and the coughing that she was experiencing was not normal. So, and this is someone who's very, very experienced. And then after the consultation, give us some written information, because that's really helpful to refer back to, because it is quite hard to take it all in. And what is very helpful is signposting to a trusted support group. In the UK, we have a great charity called Breast Cancer Now. There are many other charities out there like that. And they have nurses, trained nurses, who can talk to patients about, their issues and their side effects. And it would be absolutely wonderful if there was somebody back in the clinic that the patient could go to after the consultation, because there's always that question you think about after you've left, and you just need some kind of answer. And then I think, particularly for these type of patients who have probably been in the system a little while, many of them will want access to the research papers. So if they ask for it, provide those links, because the more informed the patient is, the better, really.
And it's very important, the communication and the repetition too, because sometimes they need to repeat the information. And clinic, indeed, I would say the role of the nurses. And we have this team of nurses who see the patient and explain the side effect, how to deal, and perhaps we will see what we can improve in the daily practice. So thank you. So, in your experience, what strategy have you found most effective for educating patients on ADC-associated toxicities, Dr. Freeman?
Yes. So when informing patients about ADC-associated toxicities, usually we're trying to educate patients early on. Sometimes the change in treatment can happen very quickly, but we do try to talk to our patients prior to them receiving the drug. That usually occurs with the physician or one of our advanced practice providers. We're also trying to provide them with something tangible that they can take home. So like an educational handout, because it can, as Leslie mentioned, it can be quite overwhelming for that consultation visit. And patients oftentimes they do have questions when they go home. So it's just nice to have a piece of paper in front of them. I also just wanted to mention that, our pharmacist also follows up with our patients and also does almost like a second teaching with our patients to answer any questions. And we obviously are ensuring that patients are aware that they can contact us via the portal with any questions that they have.
Yeah. I agree with that. And we are giving some written information to the patient, but not what I would say all the side effect, but it's a special information we did in our center with the nurses and the patient advocate, just to see exactly how to deal with side effect. Describe the side effect, what you need to do, and when do you need to report very quickly to the hospital. So, and in fact, what is important to implement strategy for ensuring prompt reporting and investigation of potential ADC related adverse events. Some may be very serious, like ILD, but even diarrhea associated with neutropenia or nausea, vomiting. So, Dr. Freeman?
Yeah, so really highlighting, common side effects, but also really going over those red flags with patients, the shortness of breath that we mentioned related to trastuzumab deruxtecan, ensuring that patients report that in a promptly time frame so that we can have them come in and assess what's happening. Any side effects that aren't being properly managed at home. Encouraging patients to reach out. And I typically will tell patients, patients come in, and I think sometimes they feel as if they have a lot of side effects that they are complaining in a sense. I've even had patients say that to me. But I try to ensure them that, this is reporting, and no problem is too small. And so we do encourage our patients to reach out as much as they need, right, so that we can properly manage their side effects.
We use some mobile applications. The patient may send what you say, some information, and we have what we call the red flags, like you say, orange or green. Is we will discuss in the further clinics.
Can I just add a comment there? I think from a patient's point of view, it's really helpful to keep an online diary of the symptoms of the problems that an individual has, and then you can easily see trends and things that a patient may have forgotten about. It's really helpful that they can perhaps bring that along to the clinic when they see their healthcare professional.
Yes, totally agree. And from my experience, when I ask, for instance, for diarrhea, and sometimes after they minimize the diarrhea, but if I see the diarrhea of the patient and see that the first day or at day 8, many stools, so we say, no, it was serious. So you forgot, but it was serious. So it's very important. Agree with that.
And I think sometimes as a patient, exactly picking up on the point from Dr. Freeman, you worry a little bit if you're complaining or that you may be taken off the treatment, and it's encouraging that partnership and it's encouraging that transfer of information, really, so that it can be managed. And as a patient, you're only going to come off the treatment if it's something very serious.
Hello, my name is Dr. Véronique Dieras, and I am a medical oncologist at the Centre Jeanne Marquis in Rennes, France. And today I'm joined by Dr. Kayla Freeman, a nurse practitioner at Emory Winship Cancer Institute in Atlanta, Georgia, USA, and Dr. Scott Edwards, a clinical oncology pharmacy specialist at the Dr. H. Bliss Murphy Center in St. John's, Newfoundland, Canada. And together, we are going to consider the identification and management of key ADC treatment toxicities in patients with metastatic breast cancer. We agree that we have the knowledge of the toxicity profile of ADC based on pivotal clinical trials. However, in the practice, in the real world, we are dealing with different populations from the clinical trials with comorbidities and co-medication. So, what strategies can be employed to avoid or mitigate ADC-associated adverse events in patients with metastatic breast cancer, I would say, in the real world outside the clinical trials? So, Dr. Edwards, please.
Thank you. Yeah, I think it's really important that we identify different strategies to help reduce these antibody drug conjugate toxicities for patients. One thing is really important: treatment patient identification up front. One group of patients that we think about are the elderly patients. And if we look back at the trials for the antibody drug conjugates in metastatic breast cancer for elderly patients, they seem to do quite well. If we also look at toxicities, some trials, though, show that they have an increased risk of toxicity. So I think it's really important for us to follow our elderly patients quite well on these antibody drug conjugates. I think it's also important that we need to think about patients with comorbidities. We know that some of these antibody drug conjugates, like TDM1, can increase the risk for things like neuropathy and even cardiac disease. For TDXD, of course, we need to make sure patients have no underlying interstitial lung disease or pneumonitis. And for SG, or sacituzumab govitecan, it's important to identify any patient with Gilbert syndrome or if they're homozygous for UGT1A1. It's also really important to identify what other concomitant medications that patients are taking, just to be aware of any important drug-drug interactions. If we look at trastuzumab emtansine, it's actually a substrate of 3A4. And just being more specific, the DM1 payload is what's a substrate of 3A4, albeit a minor substrate. But we need to be careful with strong 3A4 inhibitors because they could increase the plasma level of DM1. And it's best if we avoid concurrent use for strong 3A4 inhibitors and trastuzumab emtansine. Trastuzumab deruxtecan is pretty clean in terms of drug interactions. For sacituzumab govitecan, it's a substrate of UGT1A1. So we need to be aware that concurrent administration of sacituzumab govitecan with UGT1A1 inhibitors could increase the levels of this medication, and concurrent use of sacituzumab govitecan with UGT1A1 inducers may decrease the levels of sacituzumab govitecan. It's also really important that we identify the most appropriate prophylactic supportive medications to be given with these antibody drug conjugates. Trastuzumab emtansine has a low emetogenic potential, and TDXD, or trastuzumab deruxtecan, and sacituzumab govitecan are highly emetogenic. So you need to use the appropriate antiemetics at your institution for low and highly emetogenic protocols. And finally, sacituzumab govitecan has a potential for infusion reactions, so it's important that patients receive antihistamines and acetaminophen or paracetamol prior to infusions.
These are clearly key points. In my daily practice, I have perhaps 2 points to be cautious about. In fact, high BMI. And in fact, with ADC, we are prescribing ADC according to the weight, and perhaps we observe in the sacituzumab clinical trials, but that they may be at risk of higher toxicity, neutropenia and diarrhea. So be cautious about that. And clearly, I agree with you, Dr. Edwards, about the neutropenia in patients with high risk of neutropenia or previously receive a lot of radiotherapy to give GCSF support from the beginning of the treatment and not waiting for the first episode of febrile neutropenia. So you clearly highlight the fact that the team is very important, multidisciplinary approach as all this education for the patient, and in order to give, I would say, personalized treatment for the patient on education. And how can we best manage some of these key adverse events associated with ADC treatment in patients with metastatic breast cancer? And beginning, of course, with high-grade life-threatening side effects. Dr. Edwards?
Yeah, I think it's really important, Dr. Diaz, that we assess patients for all toxicities for antibody drug conjugates. But there are some that are more serious, and we really need, as a multidisciplinary team, to be hypervigilant. And for these high-grade toxicities, we may need dose reductions, dose interruptions, and maybe even a discontinuation of therapy. Some of these could be, an example is like hepatotoxicity that you can get with like trastuzumab emtansine. It's important that we monitor the liver enzymes prior to each cycle. And if patients get serious hepatotoxicity, then it could be a discontinuation of that treatment for that patient. Another serious toxicity that could exist is cardiac issues with patients on trastuzumab deruxtecan and trastuzumab emtansine. And more specifically, that will be congestive heart failure. We know it's really important that the patients have appropriate scans up front, so like an EKG or a MUGA scan prior to treatment and regularly throughout treatment. And then we know that if the ejection fraction gets less than 40% for these patients, it's important to hold the treatment and they have repeat assessment within 3 weeks. TDXD and TDM1 or trastuzumab deruxtecan and trastuzumab emtansine also have the risk for interstitial lung disease. It's important that patients promptly report any kind of cough, dyspnea, fever, any kind of respiratory symptoms. For grade 1 events, so this is usually asymptomatic, it could be things like a dose interruptions and a dose reduction, but corticosteroids will usually be initiated. And for grade 2 or greater events, it's probably going to be a permanent discontinuation of trastuzumab deruxtecan and the initiation of corticosteroids. For sacituzumab govitecan, diarrhea is a fairly common toxicity and has been reported in about 11% of patients for severe diarrhea. Management may be a dose reduction or an interruption. Of course, we need to evaluate for any kind of infection and advise patients to take loperamide and have it on hand as soon as they experience the diarrhea. And then, of course, to make sure the patients discontinue the loperamide 12 hours after the diarrhea resolves, and to use fluid and electrolyte replacements as much as possible. And in patients with excessive cholinergic symptoms, atropine may be used.
Thank you. And what about the low-grade side effects that may impact the quality of life? I think of asthenia, but the other one, Dr. Freeman?
Yeah, for the low-grade toxicities, of course, that are, typically going to affect the overall quality of life of our patients. Things to consider would be, low-grade nausea, vomiting, which a lot of these side effects can ultimately be managed with medication. And sometimes olanzapine, especially we utilize olanzapine oftentimes with trastuzumab deruxtecan, diarrhea with our patients who are receiving sacituzumab govitecan. So as Dr. Edwards mentioned, ensuring that these patients do have loperamide, any peripheral neuropathy. Sometimes we have to dose reduce the medications, but if we can perhaps start gabapentin, or even some of our patients are getting involved in acupuncture, and that has also helped with some of these low-grade side effects for our patient. We also encourage that patients are exercising as tolerated. And so I do find that helps not only with their overall well-being, but it helps with that fatigue that some of the patients are experiencing as they're getting treatment. And then also just being upfront about hair loss, that's extremely important for a lot of our patients. And so if we can offer a wig prosthesis for our patients early on. Some of our patients, honestly, they're still trying to cold cap in this setting as well, but doing everything that we can to support our patients as they are getting treatment.
Yeah, totally agree. And we propose calculating, but I think it's not effective in all the patients. And moreover, alopecia with ADC, it's between 30 to 40% of the patient. And I don't know why which patients are at risk of this alopecia. And even some patients experience alopecia at the beginning, and for long treatment like TDXD, after that, they recover about no idea about the mechanism of the physiopathologies of that for this ADC. It's maybe perhaps a little bit different from the chemotherapy.